we also present this at London Valve. 78-year-old gentleman, history of dyspnea on exertion for 6 to 8 months, worsened recently, hypertension, femoral fracture, sinus rhythm, LV strain, was diagnosed with bicuspid aortic valve, severe calcific aortic stenosis, EF of 50%. Now let us look at the CT scan. As we all know, CT scan is very important to plan a TAVR procedure. The area of the annulus is 507.9 millimeters square. The short axis is 21.4, long axis is 31.3. No calcium at the level of annulus. Now look at the distribution of calcium. You can also see a calcified raphe. The calcium goes all the way to the base of the leaflet, and this is a circle method. I'm not going to go into detail of this, but there's a circle method which we are using for sizing a balloon expandable valve in patients with bicuspid aortic stenosis. So we draw a circle of a certain size and try to see how that circle interacts with the surrounding tissues, how it interacts with the annulus, how it interacts with the coronary height, and how it interacts with the LVOT. But I'll draw your attention back. There is no calcium at the level of annulus, and if you can see this, there's a calcium which extends all the way to the base of the leaflet. Plan was a transcatheter aortic valve replacement under conscious sedation, right femoral artery for the TAVR, left femoral artery for 6 French artery, 6 French vein. Our plan was to do 1 ProGlide, 1 angioceal, pre-dilatation with a 22 mm, and plan was to put a 26 millimeter Edwards Sapien 3 valve. The valve is only 2% oversized, post-dilatation only if it is required. Aortogram. This is standard. We would do a 3-cusp view for a balloon expandable valve with a 5 French pigtail in the non-coronary cusp from the left common femoral artery and a temporary pacemaker from the left femoral vein. Crossing the aortic valve with a straight tip thermowire and AL1 catheter from the right femoral common femoral artery, which already had a pre-close with 1 ProGlide in place. And a pre-dilatation with a 22 mm ZMed 2 balloon on Safari extra small wire under rapid pacing. How do I go to the next slide? Okay. Aortogram with positioning of Sapien 3 valve in coplanar view, deploying the valve under rapid pacing. And we would jail our pigtail in the non-coronary sinus. Pace at 180, let the blood pressure drop, and gradually inflate the balloon. So you can see when the valve is being deployed, there is a lot of parallax in the valve. We see this type of situation sometimes in bicuspid anatomy where the parallax is there in the valve frame, but no parallax in the annulus. Immediately after deployment of the valve, the patient becomes unstable. So you can see this is the aortogram, and if you can pay some attention, there is a whiff of contrast which exits the lower portion of the valve frame. Next slide. So as soon as patient becomes hemodynamically stable, first thing is we would do a 2D echo, check for the coronary angiogram, and patient had electromechanical dissociation. Blood pressure immediately came down to 20s, and a 2D echo showed massive pericardial effusion. Even on fluoro, we could see massive pericardial effusion. Next slide, please. I'm not able to run from here. Okay. So we also took a guiding catheter to make sure there's nothing happening to the coronary left main, but you can see a 6 French guiding catheter and a large pericardial and large rent in the annulus and pericardial effusion and a large annulus rupture. What do we do at this point? Number one, so my co-operator takes the pericardial access, puts a pigtail in the pericardial space, drains the pericardium, and starts autoperfusion. The cardiac surgeon is already ready, the cardiac OT is ready, and we are about to wheel in the patient into the cardiac surgery area. But we decided to take additional a minute or two just by the clock because we don't want to give this patient when the patient is collapsing. So I took my EBU guide and I could figure out that the point of entry or the point of rent is just below the left main. Took a fielder wire. I'm trying to wire this ruptured plane, ruptured tract, and I could successfully wire the rupture. And after this, I could advance by microcatheter, which was a Nestor, which was a pro-grade microcatheter, and we deployed a Nestor coil, which was 8 mm in diameter and 14 mm in length. What do you think? Has the pericardial effusion sealed off? Let's see. And during this time, even the pericardiocentesis was going on. Patient stabilized, heparin was reversed, and the pericardial and the annulus rupture was sealed. We waited for another 1 hour or so. There was no collection. And I think the reason it worked is the valve acted as a buttress to the coils which were deployed. Next slide. This is the final angiogram, successful closure of the annulus rupture with a coil. Patient was hemodynamically stable, no more pericardial effusion. Our surgeon was a little disappointed because he was all excited to open the chest. Patient was discharged home on day 3. Patient is doing very well up till 1 year of follow-up. Next slide. Annulus rupture is a very rare but life-threatening complication of TAVR. CT analysis and proper pre-procedure planning are the key points for TAVR procedure. If you remember, in this patient, there was no calcium at the level of annulus, no calcium at the level of LVOT. Still, we had an annulus rupture, and the reason was the calcium spicule, which was going all the way till the base of leaflet. And that's why we also size all our valve also based on the level of LVOT. Sizing for bicuspid aortic stenosis is vital. Circle method helps us to understand the interaction of the valve with the aortic annulus complex. In case of annular rupture, a usual approach is a surgical conversion, but coil embolization should be attempted because emergency surgery carries a very high risk or very high mortality in these patients. Thank you very much for your kind attention.